Hello, my name is Peter Chung. I'm a developmental behavioral pediatrician and the medical director at the Center for Autism and Neurodevelopmental Disorders at University of California, Irvine. I'm honored to have been asked to give you a brief overview on specific learning disorders. Here are my disclosures, although I will not be referencing any of these entities in this presentation. By the end of this talk, I'm hopeful that you will be able to, 1, define learning disabilities and differences, including prevalence and co-occurring conditions. 2, explain the current theories on underlying neurobiological mechanisms of learning disabilities. 3, describe the ways to recognize learning disabilities. And 4, list characteristics of effective intervention for learning disabilities. I'd like to make a brief comment about nomenclature, as there are many different terms that are used in the literature and legislature regarding the topic of learning disabilities, including words like dyslexia or alexia, dyscalculia and acalculia, and others. So firstly, the term disability is used for legal purposes, often to determine eligibility for accommodations in the public realm. The term disorder is usually for medical and psychological purposes, often for the sake of identification, classification, and intervention. The term difference is sometimes used to classify individuals as distinct due to their experiences, backgrounds, or neurobiology, and is sometimes preferred because it frames the individual's differences in a less ableistic way. That is, the fact that they learn differently doesn't necessarily mean that they are disabled. For simplicity's sake, I will preferentially use the term specific learning disorder, or SLD, during this talk, but I do want to recognize that there are many different ways to talk about and to this population. Let's start off by talking about the history of SLD and then some different ways to define SLD, which is not as straightforward as you might think. The first description of learning affected by brain function was in 1676 by Johannes Schmidt. He described an adult who had loss of reading abilities, but had preserved writing abilities following a stroke. However, it wasn't until the late 19th century when learning issues were described from a developmental standpoint. That was when the first instance of the word blindness was described. The second version of the Diagnostic and Statistical Manual for Mental Disorders, or DSM, described mild brain damage, which conflated children with learning issues and attentional problems. In 1975, the U.S. Congress passed the first version of the Individuals with Disabilities Education Act, or IDEA, which has been the bastion of special education law in America since. In the initial law, Congress included the first descriptions of SLD, which we'll take a look at the next slide. And in 1980, the DSM-3 finally separated mild brain damage into two distinct conditions. One would become eventually SLD, and the other one will become ADHD. Since it was written in 1975, the IDEA has been updated and amended as recently as 2015. As you can see here, SLD and IDEA created these categories of learning issues: oral expression, or how well one speaks; listening comprehension, or how well one understands; the ability to write; the basic ability to understand letters; the ability to read words quickly, and the ability to understand what you're reading; the ability to compute math and understand math applications like word problems. The IDEA further makes a distinction that these learning issues are separate from any sensory, cognitive, behavioral, or economic factors, although, as we will see later in this talk, this distinction is not always easy to make. In the current iteration of the DSM-5, there is plenty of overlap with the IDEA. Some of the criteria include persistent difficulties in reading, writing, arithmetic, or math reasoning during school, with scores that are well below average, that have begun at least in the school age years. Like with the IDEA, the differences must not be better explained by other disorders. In addition, the DSM adds a qualifier that the difficulties must interfere with school performance, as well as job performance or performance in everyday living skills. The DSM-5 makes three distinct subtypes of SLD, which are then broken down further, albeit unofficially, into additional subtypes. Under the categories of reading disabilities, individuals may have trouble with basic phonemic awareness, that is, the understanding the relationship between letters or symbols and the sounds they make. Oftentimes, these individuals have difficulty identifying rhyming words or manipulating phonemic elements, like replacing one letter with another to make a new word. People with reading comprehension challenges, on the other hand, may not have difficulty reading, but are challenged to understand what they are reading. Commonly, individuals with reading comprehension disorders also have weaknesses in other tasks of executive functioning. For math disabilities, individuals may have trouble with completing basic numerical calculations like addition or subtraction, or may struggle primarily with math problem solving, which is often associated with language comprehension issues. Both subtypes of math disabilities are often associated with challenges in short-term or working memory. For writing disabilities, individuals may struggle with the mechanical act of writing, which may be related to fine motor or visual processing challenges, or they may struggle with the compositional aspects of writing, which requires more executive functioning and planning skills. It is important to note that individuals may have isolated or multiple different areas of difficulty within and between subtypes of learning differences. Finally, although not officially recognized by the DSM currently, there is an increasing interest and awareness of nonverbal learning disability, which can often be seen in individuals with autism spectrum disorder. People with NVLD may have challenges with concept formation, problem solving, spatial awareness, and visual perception skills. Now that we've defined SLD, let's talk a little bit about the scope of SLD in the US. It can be challenging to specifically determine the rates of SLD, as there are differences between studies on how they define SLD and how they measure that in the population. As you can see, reading and writing disabilities are among the most common, and the majority of research in the field has focused on reading disabilities, often under the term dyslexia. Math disability prevalence has ranged from 4 to 8%. Based on educational records, more than 2 million American children have some type of SLD. As you can see, this is a relatively common condition that occurs in a substantial minority of individuals. This graph shows the rates of number of children with SLD served since 1976. As you can see from this chart, the number of children served under IDA with the classification of SLD has decreased over time, with a concomitant decreasing shift in percentage out of all disabilities in educational records, despite school enrollment being relatively stable. I think this could be due to the fact that children who were previously classified under SLD may now be classified primarily under other educational eligibilities like autism. Still, intervention and support for SLD is a big issue for the American school system, given its high prevalence overall. There are certain risk factors that are associated with SLD. Firstly, a family history of SLD suggests the risk of this disorder to be related to genetics. However, environmental impacts like poverty or living in understimulating environments can also play a role. Medical conditions such as preterm delivery, alcohol exposure in utero, neurologic disorders like seizures, neurofibromatosis, tuberous sclerosis, Tourette syndrome, a history of CNS infection like with HIV, a history of CNS radiation such as with chemotherapy or for treatment of childhood cancers, and autism spectrum disorder. Genetic disorders and chronic medical conditions are also associated with higher rates of SLD. SLD has far-reaching impacts on the life trajectories of children and adults. SLDs are seen at about the same rates across all races and ethnicities, although they have much a more significant impact on those living in poverty and with most ethnic minorities. Despite being recognized as having SLD and presumably receiving some sort of intervention, many students fail to reach proficiency in reading or math in the 4th and 8th grades. As you can see here, this graph demonstrates that all children with SLD on average are scoring below the basic benchmark at 4th grade, with relatively lower performances in the Black and Hispanic population. By 8th grade, this gap widens, demonstrating that students have fallen further behind as the complexity of school expectations increase. So there's still a lot of work that has to be done to help this population. In addition, research demonstrates that those with SLD have substantially higher high school dropout rates and higher rates of criminal behaviors. Now that we understand the scope and effect of SLD, let's talk a little bit about where SLD might come from. Firstly, there are many different threads of evidence that support the concept of SLD being neurobiological. That is, the differences in academic performance is due to differences in brain function or connectivity, with the most research being done in reading SLD. With reading SLD, for example, imaging studies have shown differential patterns of brain development in gray matter and white matter, as well as divergent patterns of brain activation when conducting academic tasks when compared to control patients. Interestingly, some of these differences may be detected prior to the manifestation of symptoms, adding to the concept that these differences are related to an individual's neurobiologic development and trajectory. For math SLD, there are some studies demonstrating the complex nature of math problem solving and the need for multiple brain areas and networks to work together, including the intraparietal sulcus, posterior parietal cortex, prefrontal cortex, medial temporal lobe, hippocampus, and other areas. Imaging studies have demonstrated that disruption in one or more of these areas, or in the connections between these areas, are associated with math SLD. Finally, emerging evidence in NVLD have demonstrated that notable differences in white matters exist between cases versus controls. This image represents the differences in brain activation in patients with reading SLD on the left versus control patients on the right when they're being asked to complete a task specific to rhyming, which is often an area of weakness or challenge in people with reading disability. As you can see, there's a clear differences in the amount of activation across different areas of the brain when presented with the same stimulus in this trial. This figure shows which areas of the brain someone with math SLD may have abnormal responses when provided specific types of math problems, again demonstrating that there can be a variety of brain activation differences that underlie the presentation of math SLD. Next, SLD appeared to be genetically mediated. As alluded to previously, a family history of SLD increases the risk of SLD. The closer the affected family member is to the case, the higher the relative risk. The highest relative risk of SLD is in an individual is if both parents have SLD. Up to 80% of SLD variance is explained by hereditary factors. The specific genetics of SLD is still an emerging field. Like with imaging studies, most of the research in SLD genetics has been focused on reading SLD. There are some studies that demonstrate genetic changes are associated with differences in neurobiology or neuronal function. 9 different genomic regions have been associated with reading SLD, but there's been no strong or causal gene identified. And the issue is made more complex by the fact that there may be shared risk factors conferred by the same gene on multiple types of SLD, as well as other co-occurring conditions like ADHD. In addition, there's evidence that shows genetic factors may need to interact with environmental factors, like language exposure, intrinsic motivation, the home and school environment, or peer influences, so that genetic effects may be increased or decreased as a result. This figure represents the current understanding of genetics and their contributions to SLD. As you can see, most of the research has been done in reading SLD, with the regions highlighted in blue. Genomic regions related to math SLD are highlighted in red. And as you can see, there are specific areas highlighted in both blue and red that indicate there are shared genetic associations with both reading and math SLD. Whatever the potential causes, SLDs frequently co-occur with other conditions. The most common co-occurring conditions are another SLD or speech and language impairment, occurring in up to half of cases. Other neurodevelopmental disorders like attention deficit hyperactivity disorder or ADHD, ASD, and epilepsy are more common in SLD. Finally, psychiatric conditions like anxiety and depression, as well as more concerning psychopathology, including conduct disorder and schizophrenia, may co-occur with SLD at higher rates than in the general population. Finally, as I mentioned before, SLD is commonly seen in individuals with ASD, with up to 70% of individuals with ASD also having SLD. Some underlying challenges like difficulty in executive functioning, working memory, and attention may contribute to symptoms of both ASD and SLD, as well as the impairments related to the weaknesses. Although the majority of research has been done on the co-occurrence of ASD and reading SLD, NVLD and ASD co-occurrence is an emerging area of interest, especially with shared difficulties in visual spatial skills, nonverbal understanding, and abstract concepts commonly seen in both conditions. Let's talk a little bit how about SLDs are assessed and treated. Firstly, let's talk about some red flags for SLD. Concerning warning signs for SLD can be seen in the preschool years and may become more pronounced over time. For reading SLD, children may have early difficulty with phonemic tasks, rhyming, confusing similar letters, and may show early reading skills when they're reading by sight, that is, they're guessing words rather than sounding them out. For math SLD, children may have difficulty with counting, understanding basic math facts, and understanding math operations. Writing SLD may present with shorter written products than peers or taking extensive time to complete the same amount of work as their peers. For nonverbal learning disability, children may rely more on memorization rather than information synthesis, reading but not understanding, or having difficulty with showing or explaining their work. How to actually diagnose SLD can be challenging, and different methods have been tried over time with no current gold standard. Historically, the discrepancy model was the way to define learning disability. Thinking back to the original description in the IDEA, being able to demonstrate that an individual's cognitive potential, oftentimes utilizing the intelligence quotient or IQ, was not matching with their academic achievement, was thought to be the best way to define SLD. However, there is a lack of validity in this overall approach, and the greater practical challenge is that it requires an individual to fall significantly behind their peers before a diagnosis can be made and an intervention can be provided. That is, you may have early signs or concerns for learning disability, but it's not until they fall significantly below the level of their peers on academic achievement tests where one could make a diagnosis of SLD based on the discrepancy model. As such, this approach is no longer favored by the DSM or IDEA. The next idea was to define a learner through a pattern of strengths and weaknesses, for example, correlating someone with a reading deficit with deficits in skills of phonological awareness on a standardized evaluation. One theoretical benefit of this approach was that interventions could be individualized to learn specific challenges rather than focusing just on the academic performance. However, literature has failed to prove that this approach is either effective at diagnosis or treatment of SLD and is not currently a favored approach. Many U.S. schools currently use the response to intervention model, or RTI. In this model, there are several tiers of intervention. Most students receive tier 1 intervention, and those are the ones who are performing at or above the 40th percentile. For those students who are falling below that marker, they will be given tier 2 supplementation, which includes instruction or small group intervention. For those students who continue to fail to show improvement, they will be shifted to tier 3 intervention, which will be getting the most intensive interventions targeted towards students with SLD. The RTI approach is favored because it allows students to get support before they are defined as having SLD within the educational system. However, those children who are underperforming relative to their cognitive potential, such as those with a high IQ and SLD, would not be captured or recognized by this approach, as their skills may be average when compared to their peers, despite being below average for their individualized potential. As such, in 2002, an expert panel provided a hybrid recommendation as best practice for identification of students with SLD. That is, they recommended that a child's performance on academic achievement and other tests, as well as a low response intervention, be included for determination of SLD. Currently, many U.S. schools programs will use a combination approach where RTI is used in conjunction with a thoughtful application of cognitive and academic standardized testing to determine students with SLD. But the exact approach may vary based on state and school district, as well as subtype of SLD. Once a student is identified as having an SLD, there are several different mechanisms which can be utilized to provide support. The first type of support is accommodations, which is really about adjusting the environment to provide equal access for the individual based on their disability. The types of accommodations are individualized to the student, but some common examples include the following: preferential seating, such as at the front of the class where there are less distractions; technological aids like an FM radio to support auditory processing; typing instead of writing assignments; dictation or read aloud software for those individuals who have difficulty with writing; and access to calculators, especially if the math calculation is not what's being tested in the assignment. In addition, they can get additional time for assignments or tests; preferential testing locations, such as in a private room away from distraction; chunking of assignments, that is breaking a large assignment down into several smaller assignments, which can be more manageable for the child; as well as teacher practices like repeated directions and checking for understanding, assistance for note-taking, and many more. In the U.S., accommodations may be formalized through legal measures like a 504 plan, which then requires all teachers in that school to allow the same supports for the child, regardless of their individual teaching practices. The topic of SLD intervention is really too broad to cover in great detail here, as there are many different kinds of approaches that have been studied in the educational literature. The expert consensus recommended that all SLD interventions follow the same general principles. Firstly, they should be explicit and clearly instructing in the areas of weakness. They should have modeling strategies for learning and practice until mastery. For example, in the case of reading SLD, students who have weaknesses in phonemic awareness may benefit from explicit instruction and practice on phonemic awareness. Interventions should be individualized to the student and comprehensive to their specific and related challenges. And interventions should be provided in the context of instruction rather than isolated from actual learning activities. And finally, as is often the case, early intervention is much more effective at producing optimal educational outcomes. The general effect sizes for academic interventions, when taken as a whole, include moderate effect sizes of about 0.5 for reading and math interventions, with a stronger effect size of 0.7 for writing interventions. One example of SLD intervention is multimodal, multisensory learning instruction for reading SLD. The programs listed here, Slingerland and Lyndon Mood Bell, the Scottish Wright Reading Program, the Wilson Reading Program, Bright Solutions for Dyslexia, the Davis Dyslexia Correction, and the DOOR program all incorporate some level of multisensory learning into their curriculum. I wasn't able to embed the video into this talk, but I encourage you to watch this clip in motion at the address below. In this clip, you will see how the teacher is modeling for the class the practice of breaking down words into letters and phonemes, including a specific kinesthetic technique to reinforce phonemic awareness rather than simply spelling the word. In this clip, the teacher is pairing a specific motion and hand gesture with the letter while spelling a word. These kind of approaches have been broadly applied to reading SLD. Let's talk about adult outcomes in SLD. Many individuals with SLD can still achieve optimal outcomes as adults, but may encounter some barriers along the way. Studies have demonstrated that students with SLD will enroll into post-secondary education at the same rate as those without SLD. However, they are more likely to enroll in community colleges or big vocational programs rather than in four-year universities. In addition, they are less likely to complete college and may take twice as long to complete their education. An important contributing factor to these effects may be that the minority of college students with SLD will disclose their diagnosis or seek accommodations that are legally available to them in college. Employment status seems to be about equivalent to peers without SLD, but many surveys show individuals with SLD continue to experience job challenges related to their diagnosis. However, they still do not often disclose the diagnosis to their employers. As is often the case, individuals with multiple SLDs or other disabilities have the poorest outcomes. In these situations, advocacy, self-advocacy, and increased awareness may help the individuals with SLD achieve more success in their post-secondary education or in their employment. When looking at SLD and ASD specifically, most of the research has historically concerned the co-occurrence of reading SLD. Those individuals with ASD who graduate from high school and have spent the majority of their time in general education seem to have the best outcomes overall. However, when taken as a whole, students with ASD are less likely to graduate with a diploma and more likely to graduate with a certificate of completion and have lower rates of high school completion overall when compared to their peers without autism. This presentation really just scratched the surface when talking about SLD, and much of the data I reported on today was specific to the US. However, here are some key takeaways from the talk. Firstly, learning disabilities are common, very heterogeneous, and challenging to define, and there are different ways and approaches that you can utilize in the community or in the education system to identify learning disorders. Secondly, learning disabilities often co-occur with other conditions, including autism spectrum disorder, and most commonly with other learning disabilities or with speech and language impairment. Next, learning disabilities have an underlying biological basis that may be driven through genetics, but also interacts with environment and social determinants of health. Finally, early identification and intervention for learning disabilities can result in a positive impact, but there is a lot of work that needs to be done to optimize outcomes for this population. Here are my references, and thank you for your attention.